Good evening from Dallas, Texas, and from multiple different places around the country where our faculty and panelists are going to join us this evening. I think our webcast on modifying peripheral artery compliance during endovascular intervention, lessons learned, essentially is about atherectomy, tips and tricks, and how each one of us addresses and uses this technology to benefit our patients. So we'll give it a minute and just stay tuned. Grab a drink, grab a glass of water, and come make yourself comfortable. And we're going to have a very exciting session this evening. It'll start off with some case presentations and very exciting and engaging discussion with our panelists and presenters. So hang in for a minute or two, and we'll start sharp at 8 p.m. Central and 9 p.m. Eastern. Okay, I think we are right on time. So thank you very much for joining this CVI webcast on modifying peripheral artery compliance during endovascular intervention, lessons learned. Let me go through some of the CME slides, as this is a CME presentation, and the learning objectives are highlighted on your slides that speaks about different and current tools for crossing femoropopliteal and tibial lesions. You will see them in display in our presentations today, outline the role of DES, describe when atherectomy is indicated for femoropopliteal and tibial disease, and a list of alternative therapies for these regions. As I've mentioned before, this is CME accredited through CME Solutions. I want to introduce our esteemed panelists and faculty. Let's start with Dr. Matthew Bunte, from Director of Vascular and Medicine from St. Luke's Mid-America Heart Institute. Dr. Venita Chandra, who is a Clinical Associate Professor of Surgery at Stanford University. Dr. Lawrence Garcia, Chief of Interventional Cardiology and Vascular Intervention at Stewart St. Elizabeth's Medical Center in Boston, and Sahil Parikh, Associate Professor of Medicine at New York Presbyterian Columbia University Medical Center in New York. I also have my esteemed colleague and co-moderator, Dr. Mehdi Shishehbor from Case Western University Hospitals in Cleveland, and myself, Subhash Banerjee from Dallas, Texas. Definitely acknowledge the support of Boston Scientific Corporation, Medtronic, and Philip for making this educational activity possible. And our CME can be claimed from our website, which I will show in a few seconds. I do want to say that CVI has always had a tremendous support and participation of young budding trainees and fellows, and also early career members. I think we had a tremendous outpour of cases and submissions for our case competition dedicated to atherectomy cases. 3 cases were selected as finalists. Let me acknowledge all 3 of them first for their tremendous case submissions. It was a very, very difficult discussion, and then I will announce the winner for today's evening. All 3 finalists will be shown, and their cases will be presented and published on our website, and all of them will be acknowledged through a nationwide national and international emails that already has been sent out. So one of the first 3 finalists is Dr. Mohsin Chowdhury from Beth Israel Deaconess Medical Center, Harvard Medical School. And his case on lessons learned from SFA atherectomy was a tremendous case. And I thank him for presenting that case, sending us that case, and hopefully he'll remain engaged with CVI for many, many years to come. Our second finalist was Dr. Kays Radade from Midwest Cardiovascular Research Foundation, and he presented a tremendous case, sent us a tremendous case of instant femoropopliteal restenosis treated with jetstream atherectomy. And our third finalist and winner of this case contest is Dr. Tarek Hammad. Congrats, Tarek, and from Case Western, from Cleveland Medical Center and University Hospitals in Cleveland Clinic and Cleveland, sorry. And his presentation was modifying peripheral artery compliance during endovascular intervention lessons learned. So I know these are always very tough decisions, and we struggle a lot of who should be the winner, but I think all 3 should be considered winners and will be appropriately acknowledged. Our lineup today is going to be a case presentation, which is the winner of our case competition by Dr. Tarek Hammad. Will be followed by a presentation on step-by-step approach in modifying compliance by Dr. Matthew Bunte, and then Dr. Sahil Parikh will talk about selection of atherectomy tools and how does he look at lesion morphology and pick his best tool for that case. Directional atherectomy best practice tips can come from no one better than Dr. Lawrence Garcia, and then Dr. Venita Chandra from Stanford will share her experience with heavily calcified lesions lessons learned. So that's the lineup for this evening. I want to again share our link for logging on and claiming your CME credit for this session. And you can also access the same link for accessing our CME line at www.cvinnovations.org. Without further ado, let me ask Tarek to share the screen and present his case. We'll have a brief Q&A and then we'll launch into the faculty presentations.
Thank you so much, Dr. Banerjee and the CVI directors for choosing my presentation. It's my honor. I have two cases to present. I'm going to try to go quickly through them. First case is a CLI case, a 55-year-old gentleman with history of hypertension, diabetes, smoker. He came with a CLI Rutherford class 6. First toe on the right side was gangrene. His X-ray did show osteomyelitis. As you see, his vascular testing on the right side, we can go through, but you can see that his toe pressure on the right side is basically a flat line, 0. Here's his angiograms. We came from contralateral side, left femoral axis, big tail. You can see the iliacs and femoral without any significant disease. More selective images in the right panel. You can see the common femoral look okay. The SFA proximal segment profunda looks okay, but you can see that in the mid to distal SFA, there is multiple eccentric stenosis up to 70–80%. Now, below the knee, the AT is occluded. TP trunk is okay, peroneal is okay, PT with severe stenosis distally. And you can see the plantar artery in the foot and dorsalis pedis with some reconstitution. So basically, in summary, this is a CLI case as expected, severe multi-level disease, including severe SFA disease, occluded AT, and PT with severe stenosis distally. So what we do now? So of course, we upsize a 5-French sheath to a 655 ancel sheath. As this is a CLI case, we decide that we have to fix the SFA and below the knee disease. For the SFA, it was just severe stenosis, so we wired antegrade with a command wire, and we placed. Let's go through the options. We're just discussing, should we do a DCB with SFA only? Should we do a DCB with SFA and reconstruction below the knee? For the SFA, should we do DCB plus atherectomy, or should we do all of them? DCB, atherectomy for the SFA, and below the knee reconstruction. So as I said, because this is a CLI case, we decide to address the multi-level disease. So we decide to treat SFA and below the knee. For the SFA, our approach was, we like to modify. This where eccentric lesions, seem to be heavily calcified. We decided to modify with atherectomy and treat with DCB. So, we cross-wash command, place a filter, perform atherectomy. Now, what device? We also, as you know, we have many tools in the box. So for this case, eccentric calcium, we decided to go with HOC, directional atherectomy. So you can see pre and post on the right side. This is for the atherectomy. Then we did PTA with 5O balloon followed by DCB 6O. At this point, we removed the filter and we turned attention to below the knee disease. Angiosome base, first grade toe perfused by ATPT. We decided to go after the easy one, PT, and especially it has this large plantar branch going also the first grade toe. So we crossed, with 104 command and put a 25 a long balloon, about 150. And you can see this is the result in the middle panel after ballooning the PT. And this is, the flow now to the foot all the way to the toe. I'm going to leave the discussion to the Q&A after my presentation. So I'm going to go through the second case. Second case is a 74-year-old gentleman, same risk factors, hypertension, diabetes, smoker. He had severe claudication of his right side, also has a small non-healing ulcer on his right first toe as well. So Rutherford class 5. He previously had, a stenting of his right external iliac artery that he presented today for a stage SFA intervention. Again, his vascular testing is the right side. If we go through, you can see that the biggest drop probably across, high thigh to low thigh, from 114.75, about 40 millimeter mercury drop. So we can, knew from his prior angio that he had SFA disease, but we can tell as well from this. So SFAs have, occluded osteoproximal occlusion, and on the right side, it does reconstitute in the distal SFA. Looking at the cap, it looks like favorable, and there's not much collateral on the proximal cap, only the provender branch. The occlusion length seems to be long occlusion, and the target is a good target. So, we were discussing how to cross. So we felt the proximal cap has, favorable characteristics. So we decide to cross and try integrate first because of that. However, because of the length of the occlusion, we decide to, go with a 035 wire with the support of a navicross. So we use a stiff angle glide wire with a navicross support, and we decide to, basically subintimal dissection and re-entry. So this is our stiff angle glide wire and navicross. We cross, traverse the occlusion all the way. However, when we reach the reconstitution part, we try to go intraluminal again using an 014 wire connect to T250. This was unsuccessful. We could have gone to a re-entry device. However, we chose just to get a retrograde access. So we obtained a fluoroscopy guided distal SFA access. And as you see, this is actually a video. Let me play it. So this was glide gold from a retrograde. After we obtained the access, we threaded, we were able to externalize it through the antegrade navicross. And then, we had basically an externalized glide gold body flossing. We advance the navicross across the CTO cap to the distal interluminal part, and we rewired into the tibials. So now what? How we treat? We went subintimal, then we gained entry to the true lumen through retrograde access, externalizing the wire. So what are our options? Same as last case. Do you do just DCB? Do you do DCB plus atherectomy? Do you do angioplasty plus stenting? Multiple options: Viaband, Supera, Elovia. Again, we decide to go with debulking and DCB to maximize luminal gain and without making the dissection hopefully worse. So in this case, actually went for, because of the length of the lesion, we went with the laser. We used 1.75 turbo laser, and then this was followed by 3 DCBs, and these are the results. There's some minimal dissection, but non-flow limiting. That's it. Thank you.
Thank you, Tarek. Go ahead, Mehdi.
Tarek, thank you very much. Maybe we can remove the slides so that we can see each other. Tarek, thank you for the presentation, and you showed the 2 cases. I guess I know you're training, and share with us, and we have a lot of people on the call. We always have this challenge with atherectomy regarding data, right? We don't have randomized data. And even the selection is like, in these cases, you could have used many atherectomy devices. What is your approach as you're kind of finishing your training? How do you think you will decide which atherectomy to use for what lesion? What would be your approach in general?
Yeah, so in general, we like to, go with debulk plus DCP for SFA. And for debulking the lesion, we have, like you said, many tools in the box, but depends on lesion characteristic and morphology. This can direct us in one direction rather than the other. So most of the time, if it's more like an eccentric, calcium, we go with directional atherectomy like a Hawk. If it's if it's a long occlusion like the second case, we go more with laser. Also, laser, as we can use it, in acute and chronic cases, can use it as a thrombectomy, and atherectomy. This is, also we can use the diamond bags, the rota, but also more for eccentric lesions. With the we can use the Silverhawk as well, the directional.
Right. I guess, I would ask one more question, Subhash, if that's okay with you. I was going to ask maybe Matt, he can comment on it. Matt, in regards to the atherectomy, there is a little bit of a push, I feel, in the field regarding this concept of atherectomy plus DCB. And, even though the evidence is, there is some evidence, but, I think it's not, hardcore evidence, in my opinion. What are your thoughts about that? And has that impacted your practice, the idea of atherectomy plus DCB, minimize stenting, get a good vessel size, and those kind of things?
Sure, great question. I think Dr. Garcia has presented the most compelling data I've seen on this, but it certainly has impacted my practice. And with better and better technique on post-atherectomy angioplasty and the availability of DCB, it's certainly an important option for patients and an important part of my practice.
Fantastic. Matt, why don't you share your slide, and while you do so, I think I'll introduce your topic, then that is my step-by-step approach to modifying vessel compliance. I know there are a lot of questions, Tarek, to your presentations on the chat. I think there is one important question regarding the use of atherectomy in CTOs, and I think I'm going to just use it as a teaser for people to remain engaged, because certainly we are going to discuss this at the end of our webinar. I'm sure one of you are going to address this. So without further ado, Matt, the floor is yours.
Great, thanks Subhash and Mehdi. Appreciate the opportunity to present to everybody tonight to be part of this esteemed panel. I have no financial disclosures. My only disclosure is Dr. Shishehbor trained me, so we'll see how I do here. I think optimizing vessel compliance is a really important part of what we do, and the rationale for it is obviously it allows for proper vessel expansion so that we can get a final treatment that is going to maximize outflow to the foot and then increase distal perfusion pressure, but also minimize dissection. We, of course, have many challenges with treating long and calcified lesions, chronic total occlusions, and I've got a couple of cases where we can walk through some of the challenges that I overcame and kind of had to think outside the box in a couple circumstances. Just wanted to specifically bring up a couple issues with reduced crossing support. I think there's a bit of a push for radial access to do peripheral intervention, and I'd caution folks with interest in doing this for chronic total occlusions. In my opinion, there just isn't a lot of great support when you're going long distance, but poor runoff can also be a real challenge. We'll talk about a few of these devices, but of course there's a number of treatments to modify the vessel and calcified lesions specifically, so we'll touch on a few of these this evening. So I have an 82-year-old female who was referred to me as an inpatient who had a right fifth metatarsal head osteomyelitis. It was a pretty nasty ulcer, and orthopedics was interested in taking her leg below the knee because of the osteomyelitis and the extensive femoral popliteal disease she had. She had reasonable runoff, as you can see, below the knee and kind of midfoot. There was some evidence of microvascular disease. You can see there's a heavily calcified and long chronic occlusion of the SFA into the popliteal artery. And so we took this lady to the lab. We used the 7 French crossover sheet to park it in the right common femoral artery. Pedal access was prepped and available. We ended up using a Navicross support catheter and a hydrophilic wire to make a fair bit of progress into this lesion, but then calcium stopped us. We switched to an 018 wire, Treasure 12 specifically, and we're able to make a bit more progress. But as we went, the support catheter was really getting hung up on kind of really heavily calcified serial collared lesions. And so I ended up switching out the Navicross for a balloon catheter, hoping that I could kind of use a low profile balloon and crack the calcium as we went along. And I got some progress, but then was really stopped. And so these little blue arrows are going to represent where the really particularly calcified lesions were as we went through. And really, I got to a point where I was not able to progress any further, despite kind of using hydrophilic wires and supports, using balloon catheters to help push through calcified lesions. I was not able to get any farther with this calcified lesion, so I had to do something about it. And you know, of course, there's a number of options we could pick here, but in this particular case, I'd used intravascular lithotripsy, and I just wanted to say it's a very useful device that I've been using more and more in my practice. It uses lithotripter emitters that deliver very brief pulses with a 4-atmosphere balloon inflation, delivers about 50 atmospheres of kind of focal force pressure on the artery. And the downside of this catheter that I've come across, you have to be able to deliver it. And I was concerned about that in this case, but essentially low pressure inflation pulse, and hopefully you see expansion. So this is how things shook out. That blue arrow again is that the same space, same spot, the collar of calcium I couldn't push through before, but I was able to get the 6x60 lithoplasty balloon in the proximal segment, and you can see it actually dilated the artery fairly nicely. But then I started to get to this real collared lesion, and you can see, despite using all 300 pulses with this 6x60 balloon, I still have a severe waste. And so that's kind of like, now what? And what we ended up doing is putting in a focal NC balloon. So I took a NC quantum coronary balloon and inflated it to 26 atmospheres, and here's what it looks like. And I owe much to Dr. Shishehbor for the things he gave me during training, but he also gave me this coffee mug as a graduation gift. And so we kept going, we persisted. And so I ended up using a rotational atherectomy for this case to just buzz that really tight collar with a 175 burr. And, you know, finally pecking at it multiple times, it went, and then used a 4x20 NC balloon, and then switched to a Dorado balloon for a little more diffuse ballooning. I wanted to not do a lot of atherectomy though in the distal bed, because I didn't want to, well, for a couple of reasons. One is I find rotational atherectomy a challenge to do long distances because the rows are fairly short. And you know, there's always a risk of atherectomy. I didn't have the ability to protect the distal segment. So I ended up putting in another 660 lithoplasty balloon. And as you can see, I did serial inflations all the way down. Tragically, her femur really got destroyed in a fracture. So that was pretty dramatic to look at throughout the case. And of course, increased my radiation dose with that big nail in the femur. But after lithoplasty, the balloon actually expanded quite nicely, and we were left with the result in the middle panel there after angioplasty, and then placed supera stents throughout the femoral popliteal segment and had a pretty decent result. We were pretty happy with that. And so this was kind of the course of her ulcer. She had that ulcer removed surgically with a 5th metatarsal ray amputation, and the amputation results was good. It's kind of slow to heal, but it's definitely decreased in size. A lot of other complexities to this case for the slow healing, but overall she's making progress. So that's our first case. So the next case is a claudican, 79-year-old gentleman. I'd referred him previously for severe common femoral artery calcification and for an endarterectomy. And so he had his endarterectomy about 1.5 years before this, and was still having this terrible claudication. And we had really worked hard, tried conservative things, but he was at a point where something needed to be done. We knew he had very difficult, heavily calcified artery disease, just like the last case. You can see it's a long femoral popliteal occlusion, and his runoff was a little less clear, and obviously a lot of genicular collaterals to the lower limb. He did seem to have a nice posterior tibial artery if we needed to use that to help cross, but it looked like there was a little more extensive distal disease to this case. So I used a 7 French crossover, kind of the same sort of approach, but I ended up getting fetal access fairly quick in this case because I had a lot of heavy calcium in that distal P3 popliteal artery. So I was able to kind of shorten my CTO by getting that retrograde access and performing the angiogram. You can see the heavy calcium on that angiogram in the middle frame, and then tried to just dilate the retrograde tract to get more support and essentially cross the lesion, which I, again, kind of note as an error as 25 on this ruler here. Boy, it was just a real tough lesion to get through. And I did eventually get through it. I got through it retrograde, but I kind of took a subintimal course. And so I was not keen on doing rotational or orbital atherectomy with the lesion and how it crossed. Was able to get a 50200 balloon, and then once we externalized the wire, was then working kind of antegrade and tried a 5.0 and a 3.0 and then down to a 2.0 Takira balloon, which I've had some success with some of these heavily calcified lesions, and none of those would cross with that lesion at 25 centimeters. So then used the over-the-wire small balloons and ruptured a few of those, and then was left with a 1-2-12 over-the-wire balloon. I got it through the lesion, but then, you know, with all this back and forth and inserting equipment, the wire got bent. And now I was in a real pickle because I've got a wire across the lesion. I don't have great support, and I can't get anything to push through. So it's kind of like, now what? Well, in this case, you know, I knew I used a 1.2 balloon. So I used a kind of a step up approach with the lithoplasty balloons. The S4 lithoplasty catheter has a profile of 0.048, which is approximately what I was able to dilate the lesion. And indeed, it did kind of nose into it. And I used the whole 2540 with all the pulses in the lesion, and then stepped it up to a 6.0 balloon and did additional pulses, and actually got a surprisingly amazing result. I never would have guessed it would have cracked like this, given how hard and difficult it was to pass equipment through it. And so this is just with a balloon angioplasty. You can see the balloon expansion is actually quite good. I used a nitinol cage chocolate balloon below the knee to kind of help restore the runoff. And so this is what I was left with at the end of the case after we deployed Supera self-expanding stents within the thermopopliteal segment.
Great case,
So,
great case.
yeah, obviously resolved his symptoms. So I would say, you know, getting used to these lesions is increasingly, these are increasingly prevalent. These were just a couple cases in the last couple months. Definitely increase our procedural risk and impact results, but having a plan and being adaptive for complex lesions, I think, is important. And I have one other conclusion slide, because I know it's a big weekend and we've got a couple of Cleveland fans on here, but I would say strategy, effective tools, and adaptability conquer calcium. And with that, I'll turn it back to you guys.
That's exactly right, baby. That's exactly right. Subhash, are you taking the Q&A, or go ahead?
Yeah, I think what we wanted to do is actually move through the presentations. I've written down some really hard questions for Matt, because we will have to grill a little bit at the end, because this is a very interesting case and could have gone in many different ways. But without further ado, let's hear from Professor Sahil Parikh.
Absolutely. Sahil is going to talk about selection of an atherectomy tool. Does lesion morphology matter? And I was just going to say, Venita, I think Matt just made it a little bit harder for you. I don't know, you know, all right, thanks, Sahil.
Thanks, Mehdi. It's great to be here, and I'm delighted to talk about this topic. These are my disclosures, some of which are relevant, but I'm going to try in the next 7 minutes to really quickly go over a variety of examples. And so these are the questions I ask myself when I'm thinking about using atherectomy. In terms of lesion morphology, my major question, as you just heard, is how bad is the calcium? And we'll talk a little bit about how we might do that. Then the question that I've been asked by Subhash to answer is, do some tools work better than others for different tissue types? We'll go through 5 different examples. I do think, as Matt pointed out, that subintimal versus true lumen crossing is important in terms of device selection. And I also think, to answer Mehdi's question earlier, what definitive therapy we're going to use may be relevant in deciding what tool we use. And then, of course, the question is, what is good enough, and how much debulking is necessary? So without further ado, the first case, I call it "This Vessel's a Rock." It's similar to what Matt showed. 78-year-old Rutherford 3 intermittent claudicant, has severe calcification with SFA occlusions. This is sort of a day in the life of any of us. Severe exophytic popcorn calcium, you know, not great collaterals, and the patient's quite symptomatic. This is a fairly typical case that we all deal with on a daily basis. You can see in this unsubtracted view here, I chose orbital atherectomy, and you can see how Many of these tools will go around the calcium, and no matter how many passes and no matter what revolutions per minute you use, that's essentially what happens. You modify some of the intimal calcium, but deep vessel calcium is tougher to deal with. Balloon angioplasty looks like the balloon expands, but again, it's going around the calcium, and we don't have the kind of expansion. And I think that what we've learned from coronary intervention is vessel expansion is the key to preventing long-term TLR, whether it's thrombotic or in-stent restenosis. Here I placed a supera stent. You can see, even though I put many of these in, it's very difficult to get a perfect result. We have to stack around the calcium, but we got a pretty good hemodynamic and angiographic result. And in fact, this patient had normalization of their ABIs from 0.7 to 1.0 and was asymptomatic. So this is, I think, what most of us will do. It's a day in the life, atherectomy and stent. What about soft focal plaque? Well, this is a 73-year-old guy with prior coronary and peripheral artery disease, had a long segment SFA recanalization, and then 2 years later came back with claudication and had a focal lesion in his ostium of the SFA. I'm not sure why the movie is not playing, but assure you that this is the still frame of it. Here we decided to use, this is a filter, and this is the old LS device from the Silverhawk. And for this kind of a lesion, after atherectomy, it looks a little bit beaten up, but with balloon angioplasty and DCB, we got an excellent angiographic result. And this patient is now 6 years out from this procedure with a widely patent SFA. So I think for focal eccentric, especially soft plaque, I prefer directional. What about if you can't cross? This is an 85-year-old diabetic woman with rest pain. She had what I thought was a short, simple SFA CTO, but was so calcified I couldn't even get subintimal. Here's what the angio looks like. You'll see at the bottom of the frame, she's got a short CTO, and you can see this sort of Munkeberg's calcinosis of the media on the subtracted frame. Here, unsubtracted, you can see there's heavy calcium and nothing would cross. Stiff glide, Estado, Gaia, stacked catheters. I couldn't even get subintimal by dilating a balloon and trying to, get around this. The lady had a lot of venous insufficiency also, and a lot of venous stasis and edema. And I wasn't excited about going retro. So here I just parked a Turbo Elite laser on the cap, and at max fluency and rate, we were able to basically burn a hole through the cap, and we're able to cross with a relatively soft workhorse wire. And then, as you'll see in this IVUS, we burned a hole that's almost exactly the size of the 2.3 Turbo Elite laser. And there's heavy concentric calcium. And this is a 5.5 to 6.0 vessel. And so with IVL and balloon angioplasty, we got a pretty nice result, and then dealt with her below knee disease. What about if you get deeply subintimal? Typical Brooklyn calcium, I'll show you. 91-year-old guy with CLI with both arterial and venous disease. Here's his SFA angio, again, exophytic calcium, relatively moderate length CTO of about 10 centimeters. That's reasonably heavily calcified. Another case where I really couldn't cross true lumen, and we wound up using a loop wire technique to get across, and I just had a devil of a time because I'd made such a big dissection plane getting back in the true lumen. So we had to use outback to get back in. And once we got back, as is typically the case when you're trying to use a device to get back in, you have a deep subintimal channel. And on IVUS, it was quite clear that we had 360 calcium. We were deeply subintimal. And this is a case where I really don't want to do plaque modification with a sort of destructive debulking agent. I don't like roto or especially orbital or jet stream in this situation. And so again, I've really become reliant on IVL for this kind of a case, just like what Matt demonstrated. And we were able to dilate, and you'll see on the left, this is a post-angioplasty, and on the right is the post-supera result. And this patient healed and did very well with patency now out to 2.5 years. Last example is in-stent restenosis, a 58-year-old patient of mine who had supera stenting and then an edge dissection and came back with claudication, and unfortunately, no good deed goes unpunished. She has focal diffuse ISR in this supera stent and not in the self-expanding nitinol stent. Here's its tandem angio on the left, OCT, and you can see there's diffuse neointimal hyperplasia. For those of you that are used to looking at these pictures, there's this perfectly circumferential round supera with very, very tight in-stent restenosis. And then more proximally, there's less intimal hyperplasia. So in this kind of a situation, I think laser is a great device. This is a 2.3 turbo power, does a nice job. And you can see this is the pre and this is the post. You can see we've made a channel with the laser and then dilate with a balloon. And you'll see in the rightmost panel where there's an angio, the bottom is where we've already dilated, and above that is where we haven't dilated. And you can see that there's quite a good amount of vessel expansion after the laser, probably because of dehydration of that intimal hyperplasia. Then we finish with a drug-coated balloon, and we have a nice angiographic result. And this patient was patent 2.5 years after this intervention, fortunately. So in summary, I would say that with respect to selection of an atherectomy technique, I think lesion morphology is critical in deciding, especially when you're trying to figure out calcium. Is it deep or intimal? And is it concentric or eccentric? And I think imaging really matters. So I use a lot of IVUS in my practice. And I think that in the future, we may think that it's compulsory for complex lesions, as we now do for complex coronary lesions. When it comes to differential utilization of tools, in my algorithm for soft eccentric plaque, I like DA. I know Mehdi may talk about using it for calcium, as we heard in the first case. For severe calcium, I think orbital or rotational, like Jetstream, is a good technique depending upon the patient and the lesion. IVL is increasingly part of my practice, and I think something that we'll be using more in the future. If I'm subintimal, I really now reach for IVL first. If I have ISR or a Tufts CTO cap, I'm using laser for those cases. Again, if you're subintimal, to avoid complications, again, we'll talk about using IVL or some other techniques. And I do think, Mehdi alluded to this earlier, I think drug elution does work better when there's not diffusion barriers. The data for that are not particularly strong, but we also know that all interventions work better if you can expand the vessel. So I think in those patients in whom vessel expansion is limited by calcium, use of atherectomy or comparable techniques is important. And it remains to be seen if for drug elution, atherectomy is a good adjunct. And finally, I've gone really far away from the debulking approach, and really I try to modify plaque so that I can get good vessel expansion, as we've talked about. And my editorial comment for all of these cases that whenever I'm using atherectomy, almost 100% of the time, I use an embolic protection device. It makes for a very long and bad day, even in those infrequent cases when you have embolization. And so I just like to use it prophylactically. Thanks very much.
Thank you. Thank you, Sahil. Lawrence, you can share your screen, but I want to say that Sahil, you've done a tremendous amount of justice in 10 minutes to a very voluminous topic and to the title of our presentation. And that is why we called it what we wanted to call. I and Mehdi debated a long time what to call this talk, but you've addressed this beautifully. I want to add that there are nearly 80 attendees to this webcast, and we're getting a lot of chat questions, and I can promise you I'm writing them down on this sheet of paper, and I'm not going to let you guys go before we answer them all, and many of them have already been answered. So Lawrence, we are eager to hear from you about directional atherectomy and your tips and tricks.
I just want to thank Subhash and Mehdi for inviting me, and I can't tell you how honored I am to present for CVI, and also how proud I am of how good this conference is turning out. You guys have really deserve a lot of credit for a fantastic conference. My charge is to look directional atherectomy, and I really want to kind of go through the data set. As you know, and you've already heard, there's been a lot of issues with really scientific pursuits of atherectomy and debulking, which I think are becoming germane to this topic. These are all my disclosures. I'm going to start with two quick cases. This is both of which were enrolled in reality, and I just want to show you a kind of tale of two cases. So this is a fairly calcified artery. It was a short little CTO here. This is after we had crossed, and you can see the extent of calcification there. With good meticulous use of atherectomy followed by drug-coated balloon, you can get a very nice, pleasing angiographic result on a gentleman that was enrolled for significant claudication. And then if you look at this same case, but just a different patient, this is a long lesion of around 12, 15 centimeters, heavily calcified. And directional atherectomy is not its panacea. You can see here with this first panel, let's go back real quick. Look at the delivery of this. When that cutter gets proud, as we say, because it bows out, you can have complications, and this complication is real. So you can see how we have a intimal die cap, and it does play a role in how patients will perform. So this is his follow-up at about a year later out of the study. And you can see that with drug-coated balloon, you can actually have a complication that with, now a covered stent can be actually treated very nicely. So what about this? Well, I think we've all kind of danced around the gorilla in the room, which is that there are limitations to what we like to do, which is there is an interest in leaving nothing behind, even in complex lesions. But those limitations are driven by the impediments to delivery of drug. And that, based on the Finelli paper, tends to be calcific more than it is lesion length. However, in the definitive LE trial back in 2012, we really did show that the opportunity for directional atherectomy followed by simple balloon angioplasty was actually both safe and effective, but its effectiveness tended to decline when you had total occlusions. And as it came to longer lesion subsets, you saw a clear decline in patency when it went beyond what we normally would see in our lesion lengths in our patient population of around 10, 15, or 20 centimeters in length. That really did lead to this kind of pilot study, Definitive AR, where our colleagues out of Europe, both Gunnar Tepe and Thomas Zeller, looked at long lesions trying to compare so-called directional atherectomy and anti-restenosis therapy with with just plain old balloon, drug-coated balloon on about a reasonably long lesion subset of around 10 centimeters. And then looking at a very small group of severe calcification, about 12 centimeters, they looked at outcomes. And what they found was, this is angiographic outcomes, was that combination therapy seemed to suggest a benefit to these patient population, where the individual therapy of isolated DCB alone did not perform as well. And again, it might be this idea of impediment or being able to modify plaque prior to the delivery of the drug. So that led to the Viva Reality trial, which was presented at this year's Viva, and this is data set kindly given to me by Chris Rocha-Singh, who was one of the two PIs with Brian DeRobertis. What was most interesting is, and you have to understand, although they present on 100 patients, we enrolled 400 patients to get this 100 patients. 298 were screen fails on the table. And for this 12-month outcome, it's 92 patients. But I want you to draw your attention to a couple issues. First of all, the CTO length was 22 centimeters on average, and it was about 39% of the total patient population had CTOs. The average lesion length in the reality trial was around 18 centimeters. And the goal for reality was to look at debulk followed by drug-coated balloon. The PAC score, which was the severity looking at both sides, was class 4, bilateral greater than 5 centimeter in the vast majority of the patients. And a 55 or nearly 56% had a calcium score index of 55.7. So it was actually quite heavily calcified and quite long in lesion length. The procedure-related complications, which we should get into in a discussion such as this at the end, were relatively low. Perforations were 3.1%. Distal embolic events were upwards of 11% out of the total patient population. 99% of this patient group already had distal embolic protection. So this occurs, as we showed in definitive, regardless of whether or not you have embolic protection or not. And then those that required further work, they cut it down to the denominator being 11, but it was 1 out of the 100 that were treated. The safety outcomes when it looks at major adverse events at 30 days, which was all periprocedural, is 14%. And then you had a decline of only 7% over the following 12 months in this patient population. What's most intriguing to me is that the primary patency at 1 year was 84% in a 17 centimeter calcified lesion. And this is on par, if not higher, than many of the other trials that have gone before it, i.e. Viabon trials when it goes to long lesions such as this. looked a different way. The primary effectiveness endpoint was after the entrance into the window is 77%. And more importantly, the clinically driven TLR was a very respectable 92.6%. So again, if you look at the outcomes on directional atherectomy in a 6-minute kind of whirlwind tour, what can we say about directional atherectomy? Well, I think that first, drug-coated balloons have really dramatically changed, regardless of the current environment. I think we've all agreed that the meta-analysis is a non-issue in current reviews and the most recent data sets. The real issue seems to be where and if any, is there a need for adjunctive therapies? Is the benefit of combined therapy useful? And at least from this Viva reality trial and all the trials that have gone before it, it appears well suited for these long calcified lesions that we tend to deal with almost daily. I think directional atherectomy remains a principal disruptor. We have longer discussions about the alternatives, which would be lithoplasty. I think these are all very good questions. But these long lesions, calcified lesion plaque modification, either as a standalone therapy with directional atherectomy or combined with a DCP in the treatment of lower extremity disease, I think still is a fairly viable alternative to how we want to treat our patients with long lesions. But as my 2 cases tended to show, careful and meticulous technique, regardless of your atherectomy technology that you like, really does allow for best and most robust, the most robust likelihood for clinical success. And you have to do what you do, but you have to do it well. And I still believe that a leave nothing behind strategy for the SFA, which is an inhospitable place to begin with, really appears to be, again, a best initial SFA approach, particularly for long calcified real world patients. And how you approach it is really still up to the operator. I want to thank you for your attention.
Well, Lawrence, thank you so much. You're really a master presenter, and I've learned so much from you related to many areas of vascular disease, but definitely as it relates to directional atherectomy, there are a lot of good questions, as Subhash said. But let's finish with we saved the best for last. Dr. Venita, Chandra.
I was asked to just sort of talk about my lessons learned, so I thought I would just show a few lessons and a few cases that were particularly challenging. I was hoping to have it be really conversational and hopefully can answer some of the questions as we go along. These are my disclosures, and some of them are relevant. We've already had this conversation. Calcium is certainly a challenge. It's the enemy of the interventionalists. It's actually been described since the 16th century, which is amazing to me. And as we know, that it's both intimal and medial. And with the growing amount of diabetes and end-stage renal disease, we're really seeing a particular increase in medial calcification, which can make any of our interventions quite difficult. And the whole concept of restenosis and rebound after angioplasty, et cetera, becomes particularly challenging. We already know what the trouble with calcium is, right? There's a million of them that in overdilation in certain areas, underdilation in certain areas, incomplete stent apposition, if that's what it is. Bottom line is these are the hardest of the hard, forgive my pun, and most often excluded from most studies, except of course the reality study and a few others which have already been discussed today. But yet, many of us just keep operating and treating these patients with the proverbial lead pipes over and over. Like Matt, you showed a perfect example of ones I think we used to run from, or I should say we used to operate on in regular bypass operate. But it's really amazing what we can do with our growing armamentarium. So let's talk a little bit about that. We've been talking about debulking and plaque modification. I think there's no question that there needs to be some plaque modification when you're dealing with these particularly calcified lesions, and it depends on the type of calcium like we've been talking about. And we've discussed a few of these, and I'm going to show a couple of examples of some of them, and we've already seen some examples. Lithoplasty, of course, we've already seen. Atherectomy, and I'm going to show a couple more studies. There's scoring and cutting balloons, including the serration balloon technology, which I think is a particularly exciting one. And I have a case on that I'd like to discuss. High pressure POVA. And I don't know, have you guys heard of the Pierce and picking techniques? Our Southeast Asia colleagues describe it as like basically like sticking a needle in from the outside and cracking the calcium. And it looks so easy, but I personally haven't just had the guts yet to try it. But anyway, the bottom line is that you have to figure out your armamentarium and your tool set of plaque modification. And these amazing speakers so far have demonstrated some. So let's just go through a couple of quick cases. This is a patient, I absolutely love this guy. He's a retired 68-year-old retired naval officer. He actually presented to me for a BK. He had significant pain in his foot and this sort of obviously failed amputation, as well as progressive gangrene of a first toe amputation, which he was quickly taken for an amputation and debridement, as you can see in the picture here, clearly not adequate perfusion. His past medical history is notable for diabetes, coronary disease. Of course, he had cabbages with bilateral GSVs harvested, prostate cancer, et cetera, and he had a prior attempt at revascularization somewhere else, and I didn't really know. He had, because of his prostate cancer history, a CT scan, and the purpose of the CT scan, which I'm going really quickly on purpose because it was non-con, is you can see the glowing vessels because the significant amount of calcium burden. And you can see a big chunk within the common femoral, and this disease calcification really extended all the way down to his toes. And not surprisingly, he had monophasic waveforms throughout his leg with significant calcified plaque and multifocal high-grade stenoses and an ABI of 0.39 and a TBI of 0.18. So in summary, this is a CLTI patient with pretty significant gangrene and an infected wound that's been debrided but still infected with high-grade common femoral disease, SFA disease, and tibial disease, and extremely calcified vessels and no venous conduit. I think you can argue on multiple different approaches to this, and I think really any of them are reasonable and probably beyond the time I have to go through each one, but I ultimately chose number 3 and planned a hybrid revascularization model. So I did a femoral endarterectomy patch, and then punctured the patch, and here's what I see. And we've seen a variety of different lesions similar to this, but I'll tell you, it just makes me like cringe when I see this, because I think this kind of disease burden is one of the hardest of the hard. And Sahil in particular, I think all of you guys actually showed these kinds of cases with this very exophytic plaque in the SFA. Interestingly, his popliteal, at least by angiogram, looked okay, but we all know, right, that it actually isn't that normal. I'm sure he has a fairly significant amount of calcifications. It's just not bulky and occlusive, so I didn't necessarily have to deal with it. His tibials, this angiogram is hard to see, but he has a high-grade proximal posterior tibial lesion. Then PT is his main run-up. His AT occludes and his perineal occludes eventually. And he has single vessel PT run-off with an incomplete P large. And I don't know about you guys, but I'm particularly concerned with it. I'm an angiosome believer, and I really try to target my revascularizations in that way. And so I was a bit disappointed with his lack of forefoot and perfusion with this sort of setup. He did have reconstitution, as you can see here, of his distal DP from a collateral from the perineal, which I tried to address. So very quickly, I did a quick little PT angioplasty, but again, I couldn't help but want to try to get some forefoot perfusion. I tried antegrade to the AT and promptly ruptured his vessel. And then I decided to just try to open up the perineal through a collateral and see if maybe I could retrograde open the DP through that collateral, since it was so prominent. So I get down the perineal, open up the perineal occlusion pretty successfully, and actually get a bit into the DP, or the AT, I should say, through the collateral, but I was unable to go all the way up and open up the AT. And I decided to just let that be and balloon the collateral and see if that's enough. Collateral circulation to the anterior circulation and a good PT flow. And now it was time, and this is my completion, you can see significant improvement, I think, and I was pretty happy with that. I thought a little bit better forefoot perfusion here. So now I had to go back to this that I was clearly stalling on before and decide what to do. And we talked about a lot of different treatment algorithms, and I think, again, you could argue for any. And I decided to debulk, because I think, at this point, you needed to modify the plaque in some way. I certainly think IBL would be absolutely reasonable as well. I've had less favorable results with a really bulky plaque with IBL, but I'll say, Matt, you convinced me that maybe I just got to keep trying and go slow and keep trying. So I'll try again. So I used the directional atherectomy device, and I think I got a significant improvement, and then I proceeded with angioplasty with a DCB, thinking I'm done, and I have a very significant dissection, as you can see up here, unfortunately. And so I ultimately did place a stent in him, and I got a pretty good result. And his TBI went from 0.18 to 0.46. He did need a 4-foot TMA, but he healed up really well. And I've seen him now 3.5 years later, and he's held up and stayed open, except he had literally the exact same distribution on the other leg, but that's for another day. This is another patient of mine who's actually a frequent flyer. She's a 75-year-old woman who, the minute things go wrong, she develops rust pain and a little toe in her forefoot. She'd been revascularized by me before, as well as by other surgeons. I had previously done her AT and got her out of rest pain, and she was back now with repeat rest pain and little toe wound, as you can see, with monophasic waveform at the ankle. This is just an X-ray showing her diffuse calcified vessels. But again, for SFA actually and Profundo were all relatively normal. You could argue there's a bit of disease there, but no significant flow limiting stenosis here. This is what her distal perfusion looked like. So I was able to get across her anterior tibial. I was able to get across all the way into her heel arch here and use a small crossing balloon, pre-dilation with a 2 millimeter. And then I proceeded with the Serenator device. And I don't know if you guys are familiar with this device, but it's a balloon that has basically like serrated little blades on there. And I'm really quite impressed with this device. It just completely, the luminal gain that I saw is pretty impressive right away. And you can see here, much better flow. And because she failed with just an AT angioplasty, I just couldn't stop there. I decided to quickly get her posterior circulation as well. And here's her completion run with her AT and PT revascularized. And here's her foot arch. So I was pretty happy with this, and she really got out of rest pain, and so far so good with her toe ulcer. So I think I'm going to stop here because I think we've had some great conversations, and I just quickly wanted to show a couple of cases with a few different technologies. I guess the only different one is Serenator. But perhaps just stop sharing and see if we can answer some questions and have a conversation at this point.
Thank you, Venita. I know you've had a busy day. Go ahead, Mehdi, please.
Oh, no, thank you so much. And thank you for taking the time to join us after having a busy day with your cases and with your residents and fellows. So we appreciate it. Let me just ask one question, and then we go around and just have an open discussion. I enjoyed seeing you did an approach that is a little bit different than, at least I use, and maybe a couple of the cases that was shown today. When you have 2-level disease, you decided to treat the distal first, and then you did the proximal. I wanted to, is this normally you approach it this way? Was it a particular reason to do it that way? I know there is pros and cons, but what was the reason you did it that way in that case?
Yeah, I think that's a great question. And I'm maybe embarrassed to admit this. It's a little bit of a whim thing, not necessarily a data. I'm not gonna lie. I think it's just kind of what makes sense at that moment in time. As a surgeon, I think all of us, we're thinking about inflow and outflow. So I do tend to focus on the outflow first, just because I want to see what I can get and I want to optimize that. Certainly the argument that you could then destroy it or trash it with whatever you're doing in terms of the inflow or more proximal exists. But I, like you, Sahil, 100% of the time, if I'm going to do atherectomy using embolic protection, I'm pretty careful from that perspective. So I would say I generally do the outflow because I think it's just so imperative. And I'm almost always doing these procedures. Most of my practice is CLI, CLTI. So I'm almost always really trying to target that particular angiosome. So it's just kind of how I work.
Venita, don't be shy. Tell Mehdi Shishehbor that you are a surgeon and you want to first cultivate targets for distal bypass. And only when that distal bypass target is secured, you want to go for the more proximal lesion that we do bread and butter, like cardiologists like us, So be very brave about it, and fantastic cases. I can tell you, I don't want to take over here, but there is so much of collective wisdom in the audience. I wish I could read out their name. There are some powerhouses in the audience, and they've asked some very striking questions. Mehdi, I just want to ask a few audience questions. Is that fair? And I will start with maybe Sahil and then go around answer. The questions for Sahil, Sahil, this is a straightforward question. We all can answer it. Has the IVL technology kind of replaced conventional balloon? I think many of us are going with it straight in, or you are just showing the part of the IVL and you have tried to dilate those lesions with a conventional balloon. I think be brief, be succinct, and we'll go around. So Sahil, Lawrence, Matt, Venita, and Tarek.
Simply put, if there's deep medial calcification or 360 calcium, I think IVL works really well. And in my hands and my experience, it's been really a game changer. I think it's okay if it's eccentric calcium, you might not need IVL, but since I've been imaging a lot more upfront when I think there's a heavy calcium, and if I see a lot of 360 calcium, IVL is my first choice.
Lawrence?
Look, I agree with Sahil. I think that, we were relegated to one of the cases showed, rotational atherectomy. Very few things have survived the 1990s in the coronaries, and it's only because we have nothing else. And so in the SFA, we had really nothing to offer for these heavily calcified arteries. And I think that, progress is great. I mean, as much as I think atherectomy and debulking is a useful adjunct to anything we do, IVL may actually be the tipping point to actually make it easy. It's really going to be a cost analysis at the end of the day. It's no different than just using atherectomy directly. So, but no, I think it's a fantastic technology.
Matt and Venita?
Sure. Well, I think there's still a role for balloon angioplasty. And I think the DCB era has taught us how to properly do balloon angioplasty. And I think there's something to be said for using great technique when doing angioplasty. But absolutely, if I have to pick between rotational atherectomy or orbital atherectomy and IVL, because of the cost issues, the setup, and the risk of embolization, it certainly weighs on my mind. There are certain circumstances where there's still a role for orbital and rotational atherectomy, but I see it continue to grow in my practice.
Venita, do you have IVL?
Yes, I have IVL. Again, like I said, most of my practice, I do a lot of BTK work. And I think one of the biggest limitations there is actually crossing and getting the technology to where you need it to get in these really tiny vessels. But I don't have a particular favorite. I still do a fair bit of regular old-fashioned POVA since I just don't have, there's not a lot of tools. But I definitely think it depends on the lesion and the size. I'm not a rotational or orbital atherectomy person in general. But otherwise, I use pretty much a smattering of everything.
Mehdi, I'm going to ask you a question because there is a question for you, and then I'll pass it on to you to ask questions around. There's a question for you specifically, Mehdi. Can you specify some of the atherectomy tools that you employ in chronic total occlusions, either for crossing or after crossing or after you've done some initial treatment?
Yeah, I believe that the way you cross the lesion can impact your atherectomy choice. That's why I honestly don't like to use re-entry devices. I prefer getting retrograde access because I think that in most cases, then I can choose whatever I want. I think when you go subintimal is where, as Sahil mentioned earlier, and that orbital case that he showed, once you're subintimal, you're basically your crossing is going to determine what the atherectomy tool does. And if you're using a rotational or orbital kind of a device, it's really not going to do much to the calcium. And it's kind of ironic you asked me that question, or the audience asked me that question, because what I was going to pose is that it kind of the flavor of the month. There was a time everybody was talking about modification, plaque modification. It was a nice marketing strategy. Then it became, no, it's debulking. That's important. You want to remove things. Now we had the DART data that said not only you want to do debulking, you want to do very good debulking. You want to get less than 30% residual. And now I feel like we're going back to plaque modification. So I'm a little bit confused, I'll be honest with you, because the field has gone like 360, like we are going back now, because IVL is really plaque modification, right? We are not taking anything out. And obviously the cases that have been shown don't lie, and we use it too. But I like the idea that Venita, that I think that there is no one tool that can deal with what we deal with, and I think Matt showed a nice case where IVL didn't work, and after spending a couple $1,000s, he had to go back to orbital. and do orbital. So, you know, the bottom line is that cost is important, value-based care, you know, choosing the right device. And I agree with imaging. I think the only thing with the imaging part is that I wish we had more data to know what to do. Like, you know, it's nice to do the IVUS and do OCT, and you know, when we like it because we have experience in other areas that we use it. But I wish we knew better. Like, okay, this will translate to this. You know, like I should, because this is the way it looks on IVUS, I should use this device. And I was going to ask one question, Subhash, if that's okay. And you know, Venita kind of mentioned this nicely in one of the cartoons she showed. This concept of intimal versus medial calcification. How do you guys, like, you know, I mean, if you don't do imaging, it's hard to tell, right? So maybe Venita, you can comment, like, does it really impact how you decide, or, you know, or really not? I mean, just that.
To a degree, it does. It's more of a prognostic thing in my mind. It's more thinking about, well, I know this is just a more difficult lesion. Even if the luminogram looks okay, this is just worse pathology. And there's, you know, there's all that data in terms of just looking at the length of calcification in the foot vessels, right? And the impact on amputation. I mean, direct correlation. And that's just medial calcinosis. Whether they're open or closed doesn't matter, doesn't impact their risk. So it just, I think it's the reality. It's there. It impacts the durability, it impacts our options. But, you know, it's here to stay, I think. I don't know, I think there's much else to say.
That's a great question. But Sahil and Lawrence and Matt, do you differ? I want to provoke some debate here because you guys are all being so nice to each other. So Sahil, I think you may have a different perspective slightly from that.
Well, I mean, not per se. I mean, I think that there's a direct correlation between burden of calcium and the sort of the degree of you know, risk in both the patient and in the intervention. So I don't think there's any doubt about that based on in sort of the population-based data. On the other hand, I think from a technical standpoint, intimal calcium poses different challenges in terms of embolic risk and what techniques may be valuable compared to medial calcification. And again, I rely heavily on my coronary experience. I still think that imaging, you know, to answer Mehdi's question, imaging matters in that if you find 360 calcium or greater arc angles than 180, those vessels are more difficult to expand. And if you don't expand, you're higher likelihood of getting TLR or thrombosis, either intimal hyperplasia or thrombosis. So if our goal is to maintain patency, we need to expand. And if we can't expand, then we're in trouble. And so imaging can help you decide, do you need to do something more aggressive or less aggressive? Or do you need to just scaffold? I mean, Supera is a terrific device. And oftentimes lesion preparation and then Supera is a great 1-2 punch. So again, I think that I feel that imaging helps me make better decisions and is better than angiography, at least in terms of identifying lesion characteristics. So that's why I advocate for it.
Thank you, Sahil. Lawrence and Matt, I'm going to rephrase that question and also combine one of the audience questions and my own thoughts into this long formulation for you. It's a tough one. You know, I can tell you that in my mind sometimes, when I look at the lesion and look at the extent of calcification, sometimes you just have made up your mind that this is going to be a no stent case or this is going to be atherectomy towards facilitating a better stent result. So talk us through, and that kind of relates to Mehdi's question. There needs to be extensive amount of calcium. And what is your objective of doing atherectomy in cases? Give us like 2 scenarios, Lawrence, and 2 scenarios, Matt, and how would those final treatment decisions impact the selection of your atherectomy tool? I think because there are a lot of tools, and Sahil's presentation and his comments right now allude to that. If the stenting is the end goal, then I want a better expansion of a Supera stent, so my atherectomy choices would differ. So it's a long-worded question, but it encompasses a lot of comments from the audience. So Lawrence, please answer that, and then Matt, challenge Lawrence a bit.
That's going to be easy. Listen, I think if I can go back to Mehdi's statement, look, I don't think we have a gold standard in the SFA because I think we're all schizophrenic. At the end of the day, we still don't have a gold standard because we don't have head-to-head comparators. And, you know, we have one trial in 40 years that was a head-to-head comparator. So at some point we've got to, you know, do the thing or get off the pot, right? So in that respect, it becomes a challenge. When it comes to calcium, particularly for infrapopliteal disease, you know, POBA works, and you have a lot of people doing atherectomy where it may not be necessary. You just need to get the artery open. So to circle back now to your question, Subhash, because I think it's a telling one, is I look at the patient, right? If I have an 88-year-old person who has a wound, and I know that all I need to do is get the wound healed, I'm thinking with the calcium, I just want to get it open. If I need to stent it, I'll stent it. A leave nothing behind strategy is probably not high on my hog, you know, to get it done. And so Supera works, and it'll get him what he needs. And at the end of the day, it's a good outcome. If you have somebody who's 60 and you really think that you're going to be seeing this person back several times, I tend to try to keep my options open. So in that respect, I will throw the kitchen sink at some of these patients to try to debulk, get the drug-coated balloon, and then come back and fight another day in a similar fashion. And so that's, I don't know if if that answers your question directly, but I think that it tends to give me, you know, kind of in my own kind of crazy attitudes to how I approach patients, whether they're, you know, needing urgent revascularization or if they're going to need multiple revascularizations over time.
That's a good perspective, Matt.
Sure, thanks. You know, as you noticed, I went into both of those cases exactly the same. 7 French, so I was prepared for anything. I had the foot ready to go. One of the cases I used it, the other case I didn't. I honestly kind of anticipated putting in Supera in both of those cases because of the calcification that I saw in the CAT scan, but I didn't necessarily anticipate that one I was going to use Roto, and you know the other one I was going to just use IVL. I mean, the truth is that case where that chunk of calcium was at the kind of the adductor canal or proximal popliteal. That case, man, I was so close to giving up on, because you know by the time I had gotten through, my wire was bent. It was hard pushing equipment, and you know I kind of, as a Hail Mary, gave IVL a chance. And my decision to use atherectomy also really is predicated on, because we're dealing with really heavily calcified patients, to Venita's point, these are really high risk patients. So if you mess the patient up and you cause a complication and I have to call Venita in to help me out, boy, that's a really bad situation for the patient. So I think first do no harm. You know, IVL offers a real advantage there in my practice. But at the end of the day, I think you got to, as Lawrence pointed out, get perfusion pressure to the foot. Most of these patients are CLTI population, and I'm looking to maximize blood pressure to the foot, to the wound first, and not cause complications next. And you know, sometimes that requires atherectomy, and it's fine to use, but you also have to be ready to go when you're crossing long lesions. You don't have a lot of support to deliver a Viabond. Your Viabond probably wouldn't go through that calcified stenosis at 25 centimeters if I blew it up. And, you know, I think you have to use your head a little bit too, and be willing to come back and fight another day and try it again, a little different strategy too.
I think, Subhash, it sounds like, you know, what I'm learning from this session, to be honest with you, and through the last few years, is that, you know, it's easy to get on the podium and say that there is no randomized, double-blinded, you know, NIH-sponsored trial on atherectomy. But for people that do this on a daily basis, that they take care of this kind of patients, this group, you know, and probably most of the people that are listening to us, the reality is that, you know, we have, I think very few people would disagree that vessel preparation is important, regardless of what you're going to end up with. What is your final treatment? Whether you're going to put a stent, you're going to put a DCB, or you're going to put a covered stent, you know, whatever you're going to do, you have to prep the vessel. And that's such an incremental impact, is important, but is incremental, that it would be very hard for a company to honestly, I don't think it's going to happen. I think it's going to, I love to see it, for us to see a trial that's going to show that incremental value. So it then comes down to our own experiences as we're talking about it, and knowing that vessel preparation is important, and honestly taking it serious. I mean, I remember, you know, when I was training, we put a bare metal, you know, nitinol stent, and there would be 50% residual. And we'd be like, oh, great. And it would be 40 centimeter metal jacket. And then the patient will come back from claudication to be in rest pain, you know, 6 months later. So I think it's great that, you know, people have really changed the practice. They are paying attention. And I think that DCBs kind of shifted that, for us because, we didn't rely so much on the stents. We wanted to be better. I don't know, Lawrence, do you agree with that? I mean, what are your thoughts about this argument that folks make on the podium regarding, there is no data, there is no data? I'm really tired of it, honestly, a little bit.
Well, I mean, look, I've lived the atherectomy world since the early 2000s. That very few of us were less maligned than the atherectomizers of the world. So, look, I agree. I think that we would love to see bigger randomized trials, but we also have to agree that we just need head-to-head comparators. It's like the kid in the basketball court. We need to see, whether or not the dogma of debulking or plaque modification plays a role in how these things play out. We have all these signals that say yes. It would be really nice to show that a little bit more scientifically. And then once that is proven, go head to head and let the winners win. Because I tend to agree that what we do know in the periphery, and maybe I'm being too simplistic, but not all lesions in a claudican are created equal. And so not every one device is going to be the gold standard. So we have to have a myriad of devices that will treat a myriad of kind of outcomes that we want, but different lesion subsets which are better treated with one device versus another. And ultimately that would be the holy grail, because in the coronaries, we already know that, right? We know that short and fat is good, right? That's a good artery to have a nice small focal lesion, but a big artery. If in fact it is the diabetic of 2.0 and it's 35 millimeters, that's not going to do so well. And so I'd love to have that kind of clarity when it comes to the periphery.
Yeah, the sad part of it is that none of the cases that you guys presented today would have ever made it to any clinical trial. So that's the bottom line, and that's what we're treating. I mean, anyway, I don't know, Subhash, we're a little bit over time, I think.
Yes, I think we are over time, but we've had a superb discussion. But I think I would like to end with Tarek, because Tarek is the representation of the next generation, who is extremely talented and with a head on his shoulders. Tarek, what did you think you are going to bring to Dr. Shishehbor's lab on Monday morning when he asked you to do something? First of all, I will throw you some prompts. Do enroll the patient in the XLPD registry and do force him to IVUS the lesion. Apart from that, tell us some take-home points that you have acquired today from the various presentations you have heard. I know it was impromptu. I don't want to embarrass you. If you have learned nothing, please say so. But hopefully you have learned something very valuable from this evening.
No, of course, very nice presentations from the presenter. I learned a lot. So, bottom line, I think debulking, is appealing, and it helps, like everybody said, prepare the vessel and allow maximum luminal gain. And like Dr. Bunte, Dr. Venita, Dr. Lawrence, Dr. Parikh all went through, different cases, and they showed that sometimes, depends on, what the outcome you're looking for, what the type of patient, CLI, claudican, lesion length, lesion characteristic, ISR, CTO, different devices, a lot of tools and, a lot of options. They think individualized approach. That's about
I think that your last word is the key. What I would add to what you have said is get facile and really good with two devices, whether it is Jetstream, whether it is laser or DCA or orbital. I think get good with two devices and use, maybe in my preference, imaging to guide yourself, and use, like Dr. Lawrence said and Sahil said, use the patient profile. So, and don't be shy to call in your surgical friend, because they are, of course, our friends. So with that positive note and some vigorous questions thrown at our panel today, I bid farewell and good night to each one of you. Thank you all, our esteemed panelists and presenters and attendees, for this wonderful participation in this great webcast. Thank you again, and see you soon on another CVI webcast.
Good night.
Thanks, everybody.
Everybody. Thank you.
so much. Good night.
Good night.